let's discuss insurance plans and money and Part B and Part D, the medical benefit versus the pharmacy benefit. Save me from this. What are we talking about?
We're talking about a very complicated system.
I know
because
it's complicated. That's why you're here.
Everyone, well, we don't, that would be the next iteration of this discussion. We would have that another 90-minute discussion to
We've got
discuss
less
the
than that.
nuances. Yeah, that's what I'm looking at. But I think that, I think Joel made the point that there are so many different plans out there. It's incredibly important to understand the environment in which you are working, either as a dermatologist, primary care, or helping your patients navigate that very complicated Medicare, Medicaid, commercial insurance space.
Right.
So I think that, you know, when you're talking about some of these newer products that may literally be $5,000 to $6,000 per month for treatment, or you know, you can aggregate that over a year. You have a huge financial stake in these treatments, with maybe extremely effective outcomes for patients. So how can we help? How can we really help people, whether it be clinicians or patients, navigate the space the best? And that's going to be individual to a region, to your practice, because different insurers do different things.
Okay, now this was brought up, Part B and Part D, Bravo and Delta.
Yes.
What are those things?
So Part B tends to be the infusible kind of things. They'd be covered because you're going to a hospital-based treatment center, whether it be outpatient, you know, it could be an ambulatory, but things that tend to get infused tend to fall under Part B. There's also then Part D, which are things that could be subcutaneous or oral.
Does Part D, subcutaneous but not IV infused, cover doctor's office injections every 3 months, or does that go to Part B?
If it's something that's, if they're infusible, that tends to be something within Part B.
Okay.
Let me see if I understand things right. Part
so glad
B
somebody else is
refers to
confused.
coverage of things you have done in the doctor's office or outpatient setting. Part D covers pharmacy costs.
Correct.
So those are the two buckets. And then the question is, you have some drug that could be given at home or could be given in the office. What bucket would it fall under? And my sense is it could depend on which insurer it is. And even within that one insurer, it could depend on which plan it was with that insurer. And there's no way for me to know.
Is there a formulary difference? In other words, do some insurers simply say, these are your Part B drugs, these are your Part D drugs, this is covered if you take it at home, this is covered if you take it in a doctor's office, but this ain't covered if you go here, and this ain't covered if you go there?
Yes.
Thank you for that answer.
So the other acknowledgement here is that within the insurance world, many of these medications and pharmacy areas are actually delegated to a pharmacy benefit manager, so a PBM. And they'll be making the criteria in terms of what's covered and what's not covered at what level.
I've heard, he said, I'll bet you're going to say the same thing. Compliance is better if patients come to you, they get their injection once every 2 weeks, once every 3 months, and if they don't show up, maybe you give them a phone call and they come in and they get the drug. But if that's not covered under the formulary, what do you do then?
That's a real challenge for our patients, especially patients who have Medicare, for example, where they have big gaps in their policy. And earlier it was mentioned that, you know, oftentimes the companies that make the drugs will fill in the gaps for co-pays, for example. The patients are prohibited from that when they're on federal insurance, right? So if they're on Medicaid or they're on Medicare, they're not eligible for those sort of co-pay reduction or cost-sharing things from pharmaceutical companies. So it's a real challenge for our patients. Access to these therapies is a real challenge across the board for our patients.
There is some help for that gap with
occasionally there's sometimes foundations.
Foundation support for those people who don't have enough income to.
Right.
And so it's very, I think we have this tendency to look at the glass being half empty when the glass is 90% full. Patients come to me, they're like, Doc, listen, I'm totally uninsured. I'm not sure you're going to be able to help me. I'm like, you're uninsured? That's great. If you don't have any money and no insurance, I can get you any of these drugs.
Let me ask you this: is there a preferred drug on your formulary?
For psoriasis, there
Yeah.
is.
Which
There
one is
is. So it would be ironically, infliximab is one of the biologics that is preferred, and it's not the biosimilar version of infliximab. So you have to try and fail basically infliximab first, and then it
Okay.
can go on to other products.
So that would not be consistent with how most dermatologists think about treating their patients.
Well,
And in fact, we very seldom use infliximab for psoriasis, predominantly because one is we try to optimize safety as much as possible. We know Remicade is associated with higher rates of infections, for example, and obviously you get infusion reactions from it. So we usually don't go there. It's usually not a drug that we commonly use.
I think partly we don't use it because we don't do infusions in our office.
That's
We're like a
true.
busy ER with people coming and going, coming and going.
Yeah.
And we don't have one big room where a single nurse could supervise. But if an insurer said, do infliximab first, on the one hand I could go, well, the serious infection rate for infliximab is 3 times the rate for these newer drugs. On the other hand, I could go, well, 99 out of 100 don't have a serious infection with the newer drugs. 97 out of 100 don't have a serious infection with infliximab. Is there really a difference between the two?
Well, so when
sure, go ahead. This
well,
is likely to clear
right.
you up.
So that's the difference between an individual provider and a payer, right? So if you're a payer, you're treating potentially thousands of people, and that's where you are going to lead to bad events that could have been prevented with a different strategy, right?
And so I mean, some of the disclaimers are that if you have a counterindication, if you have some counterindication to a particular medication, and that just takes physician attestation that this person is at higher risk for bad
So
events.